right. So we have an awesome episode here today for Pounder Nation. I'm really excited to have Dr. Matt Rosen with me today.
Hi.
Dr. Rosen received his PhD from the University of Michigan. He's an assistant professor at Harvard Medical School and researcher at the Martino Center for Biomedical Imaging at Massachusetts General Hospital. His research group focuses on bridging physics to bioimaging in order to develop new methods and tools to enable unconventional approaches to MRI scanner construction. Founded in 2014, along with Jonathan Rothberg and Dr. Ron Walsworth, Dr. Rosen is the academic co-founder of the publicly traded company Hyperfine. The Nasdaq ticker is HCAQ, which will soon become HYPR. For those of you who aren't familiar yet, Hyperfine has pioneered the world's first FDA-cleared, truly portable MRI that can come directly to the patient. I just wanted my listeners to know that when I reached out to you, Matt, you said verbatim that you would talk my ear off all day about portable MRI. And then I replied to you saying that I'm totally ready to nerd out over this stuff on the podcast. But anyway, I'm glad that it's finally happening, and I look up to you a lot. So Dr. Rosen, welcome to Pounding the Table.
Thanks so much. It's a pleasure to be here. And just right off the bat, I am not a spokesperson or representative for Hyperfine. I'm speaking my own views in this regard. So, but thank you for the opportunity to talk to you today.
Awesome, of course. So without further ado, my first question for you is, could you tell us a little bit about yourself and how your career first started out? And I know it might be difficult to go back and condense probably 20 years worth of experience, but if you were to summarize just some of the earliest accomplishments, what were you most proud of working on?
So 30 years, I would say.
Okay.
So yeah, I started graduate school in '92, and my interest was really about, using physics, using laboratory-based measurements to test very fundamental things about the world, right? So people are very familiar with tests of fundamental symmetries and extensions to the standard model, and these experiments can happen at like big colliders like CERN, right? But I was really interested in what could you do in the laboratory with a small group of people, maybe just one person on the benchtop, to somehow get into these fundamental symmetries. And that work, which was the earliest work I did in graduate school, really focused on what we call hyperpolarized atoms. So transferring angular momentum from places we have it like a light beam into places where we would like to have it like a nuclear spin, so that you could do a more sensitive measurement of some particularly sensitive magnetic resonance experiment. So this wasn't imaging. This was just sort of like basic atomic physics. And by atomic physics, I mean we would use the atom as our laboratory. And then we would interrogate that system by shining laser light on it and switching magnetic fields and doing things like that. That led into applying those techniques for bioimaging. And so around the mid-90s, my advisor, Scott Swanson, had suggested we could use some of these techniques for making essentially magnetic gases. We were doing these experiments in gases like helium and xenon. We could use these magnetic gases and then inhale them and image them with MRI and get like, huge boosts in signal to noise in places that MRI is frankly rather insensitive, like the lungs. And so I began taking those experiments out of the precision measurement atomic physics laboratory, where everything was very carefully controlled, ultra high vacuum, all these very ultra clean things, building a system to generate these magnetic or hyperpolarized gases, bringing it over to the medical school and imaging them as they were inhaled into living rats and then circulated throughout the body and imaged in the brain. And so that was like my first taste of, wow, it's really interesting when you can apply these physics techniques to these problems that have to do with blood flow and brain circulation and functional activity. So it was like a really neat way to like, really break out of the sort of normal mold of fundamental physics. So your question was like, what am I most sort of proud of in those days? I love the experimental part of experimental physics, right? Building things. And so I built a lot of technology early on that was very robust and portable and could be used to interface with at that stage, it was a 2 Tesla animal MRI scanner, and was able to, basically leverage everything I knew about careful measurements, data analysis, data reduction, for a problem that I was learning about in the bioimaging space. So that was like definitely something I'm quite proud of.
Awesome.
And then I guess,
Mm-hmm.
Karen,
yeah, go ahead.
So carrying it forward, then 2001, I came to Harvard to work in Ron Walsworth's laboratory.
Right.
And so Ron, who was an old friend of mine, Ron's group at Harvard was kind of all of that same stuff. It was based again in precision measurement and fundamental physics and hydrogen masers and astrophysics and all sorts of amazing things. And also had a real interest in bioimaging. And so the plan was to take what I knew about hyperpolarization, bring it to Harvard, and then cross-pollinate and see what other kinds of interesting things we could come up with.
Awesome. So you first started using your experience with hyperpolarization and NMR, and then you took that and applied what you knew for lung imaging. Ultimately, you ended up studying neuroimaging. So I'd like to hear about how that all transpired. And I'm also aware you received a grant from the Army for sort of like a skunk works, or you also call it a Manhattan Project of some sorts, right, where you researched traumatic brain injuries on soldiers. So how did that spearhead your understanding in brain physiology?
Yeah, so rolling back just slightly. So when I got to Harvard, one of the projects we were working on was a grant from NASA. NASA was really interested in understanding how the heart-lung system was impacted by gravity. And so, for instance, astronauts on the space station and zero-G environments. And so we had this idea to use hyperpolarized helium imaging and then have the person subject stand up and lay down and study how oxygen, ventilation and perfusion were modulated by the presence of gravity, right, or the orientation in the gravitational field. Unfortunately, you can't stand up in a standard MRI scan. And so that meant that we had to build our own MRI scanner. And so starting in 2003, me and my then student Leo Tsai designed and built a ultra low field 6.5 millitesla MRI scanner for the express purpose of imaging the lungs. And actually, even more specific, imaging hyperpolarized gas in the lungs. So we didn't think that we could do really good standard MRI because the magnetic field was so low. But when you have a huge magnetization that comes from this hyperpolarized stuff, you don't need a large magnetic field. Your signal comes from the laser, essentially. So we built that thing and we started taking data throughout the early 2000s. 2009, I moved over to the MGH Martino Center to do more, lung imaging really with hyperpolarized gas in a more clinical environment. And I got a grant 2010 from the Army to basically say, okay, could you leverage everything you know about this millitesla MRI for looking at warfighters in theater? And the reason they wanted to do this at low field is very simple. Traumatic brain injury, in particular closed head TBI or mild TBI, was really getting a lot of traction. And the etiology of the secondary processes that happen after the impact are not well understood. And MRI, of course, is the undisputed champion of neuroimaging, right? But if you put a 3 Tesla magnet, in theater, and someone may have shrapnel in their body, that doesn't end well. Yeah. And so it was well known that the only way MRI could work outside of the controlled access environment, right, of a radiology suite is at low field. And so, it was a big grant. It was my first big grant. And I hired all these great physicists and engineers as postdocs. And we developed over the next 4 years a bunch of technology that really leveraged the fact that, okay, we were doing this in the 2010s, 11, 12, 13s, not the 1970s, right? So MRI, actually going back even further, NMR, nuclear magnetic resonance, the measurement technology for MRI, it's very old, right? And it started at low magnetic field because that's what people had. And there's been a push to higher and higher magnetic fields that improves the performance in general. But also lots of things have happened, right? Compute has gotten better. Radio frequency electronics has gotten better. Algorithms, machine learning, deep learning, tons of things have happened, as well as the magnetic fields going up that improve image quality. So we decided to say, okay, how good can we get if we just take the magnetic field out of the equation and take state-of-the-art, 2010, 11, 12, 13 MRI, like people like Larry Wald, my colleague at the Martino Center, were doing for state-of-the-art high-field MRI. And could we take some of those things and put them into our little, 10 horsepower go-kart? right? And what sticks. And some things work and some things don't work. So it was a really kind of exciting time for us. And that culminated really in a paper which ended up getting published, I think, in 2015, showing that even at 6.5 millitesla, we could do pretty good MRI, non-hyperpolarized MRI in humans in 6 minutes, 2.5 millimeter in plane, like not the greatest thing in the world. But if you're looking, for instance, to identify, oh, this person has a ischemic stroke or hemorrhagic stroke or some other, it's fine.
Right. So you mentioned the Martino Center, and I know that collaborative work is really important to you, Matt. So what's it like working there and pursuing collaborative work with clinician scientists like Bruce Rosen, who you deem as like the father of fMRI?
Yeah, so no relation to me. So yeah, Bruce leads the Martino Center, which is this amazing place because, it's physicists and engineers, all who have a kind of a common goal of advancing healthcare technology, right? And it's certainly true that when I was in the physics lab over at Harvard, we felt like, oh, we're doing medical physics. We're doing things that are like medically related, but we didn't really know what we were talking about. And it's very rewarding to sit down in front of, say, a neurologist and have them tell us, okay, look, this is the cascade of disease processes following traumatic brain injury. You get overproduction of free radicals, and then this causes secondary edema, and that causes like all this stuff that we have no idea about. And in my own case, for instance, in that case, I had to go look up what is a free radical. That's some kind of chemistry thing, right? I'm a physicist.
Yep.
And then I realized, oh, it's an electron spin. It's simply an electron spin. And we know how to actually do hyperpolarization, transferring angular momentum from electron spins into protons. And so we could actually, at low magnetic field, add some interesting physics via what's called the hyperfine interaction to essentially give free radical contrast to low field MRI. And the cool thing about this whole thing was, okay, I learned a lot of neurology. I learned a lot of neurocritical care things. I have tons of these clinician scientist collaborators. But this was my very first taste, other than the sort of mundane use case where operation at low magnetic field is safe, right? This is the first case where there are things possible at low magnetic field that are not possible at high magnetic field. And in the case of free radical imaging, it turns out that to do this at, say, 1.5 Tesla, you need to resonate the electron spin, which is in the sort of 50 gigahertz microwave region. So that would mean irradiating the patient or subject with microwave energy, generally not a good idea.
Right.
But at low magnetic field, that frequency drops. And so you can very safely do in vivo electron saturation and measure these free radicals at low magnetic field. So that, it's a long answer to your question, but basically learning about what are the contemporary questions in, again, I love neurology. So, in neurology and neuroscience, what are the questions that people really want to know? And then having these conversations that allow us to sort of break it down into language that I as a physicist understand, and then we sort of go away and rebuild it into hopefully some useful tool. And that happens, I would say, throughout the Martino Center. There are chemists and physicists and engineers working in multiple modalities, generally in the MRI world, again, all in service of neuroimaging.
I love it. I love that you all leverage each other's specific expertise and what you're all good at. I love that.
It's a much different kind of collaborative environment than what you find in a traditional, let's say, physics department, right? In a physics department, there are a lot of chiefs. They have their groups. They are more or less siloed. That's just the culture. Postdocs from one group don't necessarily talk to postdocs from another group. It's not that way at our center, where everybody talks, because everybody kind of relies on each other. We're all in this soft money world. We're all on each other's grants. We're all doing interdisciplinary to a different degree. So it's quite a wonderful place. It's a very creative place to do research.
Right. And I think that's a really good background. So now that we can pivot more towards the commercialization of low field MRI. So as many of the listeners know, Jonathan Rothberg is an entrepreneur known for inventing high-speed next-gen sequencing. More recently, he's known for co-founding several companies like Butterfly IQ, Quantum AI Therapeutics, and Health Tesseract, just to name a few of them. Dr. Walsworth is currently senior physicist and serves on the academic advisory board for Quantum Sci and Butterfly Network, which has brought to market a handheld ultrasound that is read on an iPhone and costs less than $2,000. So, of course, you're all listed as co-founders of the publicly traded company Hyperfine. I'd like to hear how the story. I'd like to hear the story about how this all transpired. Who approached who with the idea of commercializing a low-cost portable MRI, and ultimately, could you explain your relationship with Jonathan and Ron, and what it's been like working with them on different projects? Because it almost feels like this was fate, combining yours and Ron's experience with the commercialization experience that Jonathan has.
Yeah, it is a great story, and that just reminds me of a thing that people know this expression, but I first heard it from Jonathan. If a spaceship lands in your backyard, you get on, right? And that's really what it was. So of course, I postdoc with Ron Walsworth in 2001. I knew him back into the 90s when he was had just gotten his PhD, and I was starting graduate school. So we're old friends. We have similar tastes, I think, and sort of ways of doing things. And Ron was on the advisory board, I believe, of Butterfly and QSci at that time. And Jonathan, every year or so, put on this scientific program at Carnegie Mellon, where he would invite people doing imaging science and all different modalities to go and present what they were working on. And I later came to understand that Jonathan kind of used this as a way to it was like his distant early warning as to like what's hot, and he would handpick the people that would come. And so I gave a talk, maybe it was 2012 or 2013, about the work we were doing. Again, the work in my lab with low field MRI was like very immature at that time. And he was pretty unimpressed because I gave my talk and that was it. Ron introduced us and I gave the talk and that was it. And then like a year or so later, Jonathan wrote to me and said, I want to build a $50,000 MRI scanner. And I said, well, we're already doing that. Of course, as an arrogant physicist, because we weren't actually selling anything, we weren't actually building anything, but we had a test bed system that you could build for, with it given economies of scale, you could build those things. It wasn't miniaturized; it was full size, big thing in my laboratory. But we had demonstrated, all of the sort of things you need to basically say, like, yeah, this is an existence proof that millitesla MRI can be a thing. And so we all got together, Ron, Jonathan, and I gave a pitch about the work we had done at that time. That was 2014, which was greatly improved compared to the work I'd shown him previously. And like right on the spot, he said, okay, let's found a company, and again, kind of as an arrogant physicist, I was like, let me finish my slides. I distinctly remember this, I had like 40 more slides, but Jonathan had decided. And so he let me talk a little more. And then he said, look, I've seen enough. Jonathan has this amazing vision. Anybody who knows his reputation or has worked with him, will agree to this. He can kind of see the future in a really interesting way. He picks up on like the scent of something that's going to be difficult and world changing and also possible, right? I mean, I think it's the last thing that separates the grown-ups from the children. Right. Because like you could say, oh yeah, we're going to have anti-gravity. Wouldn't that be great? But okay, that's not happening. And so he picks his problems very carefully. And when he had identified that, we could really leverage all of the amazing engineering that was happening down in Guildford with the physics that we were doing in my group, it was an amazing opportunity. And for me, as a physicist, I work on a problem until I'm like, okay, well, now it's all engineering after that, right? And boy, I'll tell you, in the early days, I worked very closely with the engineers at Hyperfine, and they're just all absolutely incredible. Taught me things about product design and economies of scale, and really like every single component. You think about the Hyperfine scanner. There was this target price of $50,000.
Okay,
right?
yeah.
MRI scanner costs like a few $1 million, right? So every single component that was picked to do the job of this scanner, if it didn't add up to less than $50,000, Jonathan wouldn't allow it. This is really remarkable. Remarkable. Talk about a Manhattan project, right? That was a extremely focused, deep dive engineering that ultimately involved lots of people. And it's just incredible. So the product now is, of course, a real thing. and it's out there, saving lives and hopefully changing healthcare.
I also love that Jonathan is very quick to give credit to his engineers. Like he's very open about how much they do, in terms
Exactly.
of for what the company and for the patients that these products are going to be, going out to.
Right. That's right.
You touched on this a little bit before. I just want to bring it up again, but where did the name Hyperfine come from?
Yeah. So one of the most exciting things, as I mentioned, that I was doing at the time was this ability to image injury, the mechanism that's involved in injury, this overproduction of free radicals at low field. And the physics technique that's basically describes the interaction between electrons and nucleons. So electrons and protons, or electrons and neutrons, is called the hyperfine interaction. And so that's why I named the company Hyperfine, or Hyperfine Research, in the early days. Again, because it sounds pretty cool. But also, one of the interesting goals is, again, are there things, it's one thing to be able to do quite good MRI at low magnetic field, not as good as what you can do at 3 Tesla, but quite good. It's another thing to say, well, there are applications that are only possible at low field, like this free radical imaging I was talking about. There are hosts of other things like that as well. And so, I think the name speaks to the sort of strong points about what's possible. There are unexpected things that are possible at low magnetic field operation.
I love it. And speaking of what's possible at low field, Matt, I'd like to point out 2 significant studies that I'm sure you're familiar with, and these both highlight the capability of low-cost portable MRI. So on August 25th, an open access study was published in Nature Communications from Yale New Haven Hospital by Kevin Sheth. The study compared the abilities of 6.5 millitesla portable MRI versus
64.
CT.
So that's
64 millitesla.
So this is slightly confusing. The scanner in my laboratory, our research scanner, is 6.5 millitesla. The Hyperfine scanner is 10 times higher, 64 millitesla.
Okay. Good catch. So the study compared the abilities of a 64 millitesla portable MRI versus CT and a 1.5 to 3 Tesla conventional MRI to evaluate intracerebral hemorrhages known as ICH. So ruling out an ICH is often the first step in patients suspected of stroke or trauma. So I'm going to cover what the basic interpretation by neuroradiologist was. The overall accuracy was 90%. ICH sensitivity was about 80%. Ischemic stroke had 96.6% specificity. So those were just some those are some key points I really wanted to hit on. And similarly, on September 8th, Kevin Sheth from Yale Medicine published a study to determine if brain injuries in patients who are critically ill can be assessed using a novel portable low-field MRI device at the bedside in an intensive care setting. So the research is the first known attempt to deploy a mobile bedside magnetic resonance brain imaging device. So I just wanted to see, a little bit about your thoughts, what you thought about those studies, and if there's anything I didn't really particularly hit on.
No, that's exactly right. So you described them in the reverse order. So the first paper, and I'm an author on both those papers.
Sorry.
No, that's fine. So the work is really led. There's a collaboration between Kevin Sheth, who's a neurocritical care neurologist at Yale New Haven Hospital, and Taylor Kimberly, who's a neurocritical care neurologist at the MGH, and me. The 3 of us are the co-PIs on a grant from the American Heart Association, which we got a few years ago. It was a collaborative science award to actually deploy the Hyperfine scanner for real, in a neurocritical care situation, starting at Yale New Haven Hospital. Now there's also scanners up here at the MGH.
Okay.
And then COVID happened, right? And this remarkable work by Kevin and his team, what they showed was that, not only can you put a scanner, again, not in the controlled access environment of a radiology suite, but in the patient room of the ICU, but there are use cases, again, much like what I was saying about free radical imaging. There are things that are only possible at low magnetic field. Number one, which we talked about earlier, if you put a 1.5 Tesla scanner, I don't care if it costs $1. If you put one in the neuro ICU, someone's going to get hurt.
Right.
Because it's respirators and oxygen, and can't do that.
Right.
Number one. And number two, because it operates at low magnetic field, because of its form factor, because of its open access design, and because of some of the noise cancellation technology, electronic noise cancellation technology, you could scan subjects for which you wouldn't generally transport to the neuro ICU. From the neuro ICU to the radiology suite for MRI. These were comatose patients in the COVID ward, right? They were all ventilated, or many of them were ventilated. And so to consider moving someone, down to radiology to scan them and disconnecting the vent and reconnect, you don't want to do that.
Right. Yeah.
So this was a remarkable tour de force study. And in that study, the images that are shown in the JAMA Neurology paper, they show the images that are shown, very significant neurological problems, strokes in a couple of the subjects. These are subjects for which a normal neuro exam was unattainable because they were comatose, right? And so big picture, we now have a device, this Hyperfine scanner, that can give you insight into what's going on, neurologically, anatomically in the heads of patients, which you would not probably transport them for MR.
Right.
Just an amazing result. And then the most recent paper, which you summarized both of these very well, the Nature Communications paper, a very deep dive into using this for stroke triage. And you mentioned that there were, it doesn't have a 0% false negative. It has a finite number of false negatives. Again, this is evolving technology. I am not off-put by that. I'm quite enthusiastic about it, right? Again, the resolution of CT, as you know, is quite high. It's sub-millimeter. The resolution of 1.5 TMR is millimeter roughly in plane. The fact that we can detect these kind of, bleeds with the Hyperfine scanner is remarkable. And I think it's, as the acquisition protocols get better, the pulse sequences, as the reconstruction software gets better, as the kind of AI guided deep learning, automated stroke detection models get better, that false negative rate will decrease.
Right. So I think that's actually a really, really good transition for the next couple of questions that I plan to ask. So typically a small healthcare facility with a single MRI machine may perform somewhere around 6,000 scans per year, while a major medical center with several machines may perform 18,000 scans annually. Matt, do you foresee conventional MRI and Swoop being complementary to open up accessibility to conventional MRI?
It's such a great question. Well, yes. I mean, the simple answer is yes. Just like, your average neurologist in your, average hospital, they still have a stethoscope around their neck, right? These low-cost devices can give you information that does not replace what you get, say, from a head MR, but is cheaper, ubiquitous, faster to deploy, things like that. And so I can remember very distinctly 12 years ago when I was working doing low field MRI and talking to, I won't say who to protect the not so innocent, but very smart people at some of the major, top 3 MRI companies, right? And they would saw what I was doing and they understood the military medicine and all that stuff. And they said, you're never going to replace multi-Tesla MRI. I said, I don't want to replace multi-Tesla MRI. And it was like, they couldn't get it. And so the analogy I give is like, so I was born in 1970, right? So like in 1970, you couldn't sell for any amount of money, like a tiny little car, maybe a 2-seater, that got, let's say 100 miles per gallon. You couldn't sell it because nobody wanted it. But in 2021, here in Cambridge, right, you could sell that to people. That would be a compliment to maybe their larger car that they use for like weekend getaways, right? Oh, I see. Purpose-built things, right? Oh, it's easier to park in the city. It gets better gas mileage. It's better, all of these things. So again, these technologies are complementary, absolutely. Right. And I think the really interesting thing that's got me so excited are, okay, the MRI scanner is now no longer in the radiology suite. What other things can we put in there? That sounds like a blender, I don't mean it that way, but for instance, like what other use cases can we have? Just things that we haven't imagined because it's never been possible. Like, can you do image guided physical therapy just to make up something, right? Like, let's say someone's got a pulled elbow, I don't know, and so that someone wants to do some, massage or manipulation, like, can you make that somehow more quantitative with MRI? Right. Well, if you're paying $2,000 an hour to get a high field MRI scan, you're not going to do that. But if you could do it for very low cost, maybe those cases become interesting.
Right.
It reminds me a lot of when I was a kid. I heard these stories from my father about how the shoe stores in the old days would have x-ray machines like Buster
Wow.
Brown. And they would, yeah, right. And they would x-ray these kids' feet to see how the shoe fit. Now, 2021, we realized like, wow, bad idea, ionizing radiation in kids. But don't think about that for a second. Think about how clever that was, right? You're trying to fit a kid with a shoe. Maybe they can't tell you, they can't exactly communicate if it's too tight or not, whatever. And so you have a non-invasive tool that can give you information. You could do that with MRI. I'm not saying we should use a Hyperfine scanner to fit shoes. But again, once you have low cost, three-dimensional non-invasive imaging, like, wow.
Optionality.
You could do all sorts of things. There's just, endless ideas. Shoes is just, you throw that one out, but or not. But there are tons of things that you could come up with, that clinician scientists could come up with, any number of things. So complementary, yes. And then also, so there's some overlap, but then there's also a space where the Hyperfine scanner or other low-cost scanners will really shine.
Right.
And those things are, again, because of their ubiquity, their safety, their open access design, their portability, et cetera.
So I'm really interested to see use cases, because sort of like you can't think of what's to come or what is possible until you see somebody else do it, and then it becomes normalized, and then that's
right, exactly. That's exactly right. You just try all sorts of different things. There's so many creative people in the world, and if you said, look, I have safe three-dimensional non-invasive imaging, what would you like to do with that?
Right.
Oh, geez. I mean, you may not know this, but NMR, nuclear magnetic resonance, is used to look at wine, for instance, in the bottle, right? And you can do all sorts of stuff. You can tell if the wine has been corked or not, or is counterfeit, right? And so that's a non-imaging approach that uses magnetic resonance. Again, that's an application that, like, the chemists back in the 50s would probably never have thought of. Right. So just like letting this tool out into the world. It's the same as, what Jonathan has done with the butterfly scanner, right? Ultrasound, ultrasound's been around a long time. Jonathan's team did amazing things to miniaturize it and lower the cost. But like, more important than that, I would say, is the ubiquity of these tools now. And they have this great interface that uses an iPhone, and it helps you, figure out where to place it. Right. And so people are doing all kinds of things, looking at all sorts of body parts, getting more data about the range of normal, and just learning about the diversity of applications just by doing. And so it's going to be the same thing for MRI, in my opinion.
So, Matt, I just want to clear something up for the listeners, because as I mentioned to you before, we have some listeners that are versed on this and some that aren't. MRI is generally very safe. So when people think of conventional MRI, they think like, this huge magnet, and that's probably typically what people think about, like when they think about the negatives of MRI. But MRI in general is safe. It's not like X-ray. It's not like invasive, right?
Right. So that's right. So it uses radio frequency pulses to interrogate the nuclear spins in your body, the water protons typically in your body, and their magnetism. But that radio frequency energy is non-ionizing. It's like radio.
Right.
Correct. Okay. The only danger, essentially, for traditional high field MRI is flying projectiles and incompatibility with the large magnetic field. That's why you go through a metal detector before you go into an MRI scanner room. That's why there's a door to the high field scanner room. That's why you answer a questionnaire if you have any metal in your eye, etc. So by turning the magnetic field down, those precautions go away or are significantly reduced. If you look at the photos in the JAMA Neurology paper of the Hyperfine scanner in the neuro ICU, there's like ventilators and oxygen tank, all those things right there. It's amazing. And that's a fundamental paradigm shift.
I love it. And so as far as imaging goes, what compute techniques can we use to improve the imaging quality of low field MRI? And is that what AutoMap is for? Could you explain AutoMap a bit in layman's?
Sure. So that's a really interesting question. One of the most exciting things I would say in contemporary MRI, reconstruction. And so what reconstruction means is you acquire data on your MRI scanner, right? By playing what we call a pulse sequence. You get this data, and then you do something to that data to come up with the final images. We call that process reconstruction. And traditionally, reconstruction is done using analytic transforms like the Fourier transform. Just straightforward things that every physicist learned when they were like wearing short pants, like very simple stuff. But again, as compute gets more advanced, people are looking at all kinds of different approaches to reconstructing data, including sort of model-based things broadly known as magnetic resonance fingerprinting. And then in addition, people are using deep and machine learning approaches to reconstruct that data conditioned on natural sparse properties of the data as a way to sort of reduce the noise level. AutoMap, which is something that we came up with in our group, and work led by my postdoc, Bo Zhu, automated transform by manifold approximation. It's a paper we published in Nature a couple of years ago now. It treats the whole MRI, or actually any imaging modality process from data acquisition to reconstruction as a supervised learning problem. And so it's trained on the so-called forward model of the physics that describes the way you acquire the data. And then once trained, it can almost instantaneously invert that forward model. And we've shown both in the original Nature paper and in a paper we published this year in Scientific Reports and work led by my postdoc, Neha Kunju, she showed that you can greatly improve the signal to noise, essentially by reducing the noise floor and by boosting the signal a little bit. With low field MRI, again, work done in my lab at 6.5 millitesla, so much noisier, much lower quality data than what's done at the Hyperfine scanner, using these learned approaches. And AutoMap, that's our favorite paradigm. There are lots of very interesting machine and deep learning approaches that operate just on the image domain. They can take a low resolution image and make a high resolution image, so-called super resolution techniques. There's a whole bunch of things out there in the world. There's more papers than you can shake a stick at. All of these technologies, I think, are definitely extremely welcome in the field of low field MRI. If you have tons of signal to noise, if you're making images that are like very low noise, 3 Tesla, 7 Tesla, maybe you don't need them. But if you have, kind of slightly grainy images, like the kind of thing you get, like if you take your smartphone and operate it, indoors in a dark room, these computational approaches, computational photography approaches, computational reconstruction approaches can really improve the quality of what's possible. So that's just like a super hot thing right now. We're very involved. The name of my laboratory is the Low Field MRI and Hyperpolarized Media Laboratory. That covers 2 legs of the 3-legged stool. The third leg is I'm the co-director of the Center for Machine Learning at the Martino Center. So we have all 3 things operating together to try to improve that technology.
Amazing. So Matt, are there any sequences that are particularly challenging for low field? I'm going to say this correct now, 64 millitesla. So anything challenging there?
Right. So people who are familiar with MRI at high magnetic field, they know there are certain sequences that are noisier than others. And diffusion weighted imaging is one of them, particularly as you go to what's called high B value diffusion. And so anytime you are signal to noise starved, it gets challenging. It gets harder at low magnetic field. It gets harder at 64 millitesla compared to 3 Tesla, and even harder at 6.5 millitesla compared to 64 millitesla. And so, again, that's a place where these deep learning approaches can really boost performance.
Awesome.
And so, yeah, there are certainly sequences that are hard. High B value diffusion, very hard, but actually in the Nature Comms paper and in the JAMA Neurology paper, I think we show B of 800. If you look at the image quality of those images, those are the lowest quality from a signal to noise perspective. Okay. But signal to noise, image signal to noise isn't the full story. It's about, what kind of information can you get out of that image? So for instance, this is back when I had this grant from the Army, I would talk to these neurointensivists, these Army docs, and they would say to me, I don't care. Actually, they typically would use an expletive, but I'll leave that out. I don't care if I only see one voxel that's the size of the head. And if you can make it glow red if there's been a traumatic brain injury, and green if there hasn't. That's enough information. And so, as we get to civilian medicine, more specific pulse sequences that can, elucidate changes in, say, diffusion or other kind of, brain issues, you may not always need the highest resolution or the highest signal to noise. Of course, radiologists, neuroradiologists, they like looking at very nice, pretty pictures, and they are the final arbiters of the interpretation of the data. So anything we can do as physicists to improve image quality, of course, is always welcome.
And speaking on image quality, gadolinium contrast is used in about 1 out of every 3 MRI scans to improve the clarity of the images of the body's internal structures. It improves the diagnostic accuracy of the MRI scan and often improves the visibility. So my question is, will we ever be able to incorporate gadolinium enhanced imaging for portable MRI, or do we need to discover alternatives, perhaps the use of SPIONS?
Yeah, so in my lab, again, from a research perspective, down an order of magnitude lower at 6.5 millitesla, we published a paper last year in Science Advances led by my former student, David Waddington. And we showed, again, at our ultra low magnetic field, you can't give enough gadolinium to get contrast at low magnetic field without going over the FDA limit. And so again, that's in my laboratory at very low magnetic fields.
Okay.
And so in that case, that's a problem. If you're trying to have a contrast agent that can tell you about, blood-brain barrier breakdown, which is things that people care about a lot, what do you do, right? And so our paper was about the use of superparamagnetic iron oxide nanoparticles, or SPIONS. And these little buggers, they are great for contrast at low field. They have huge magnetizations. You can actually use them in a couple interesting different ways. Just by changing the way you acquire your image, you can get dark contrast from their presence, traditional, that's the kind of way you get relaxation contrast, or bright contrast. So you can use them as either relaxation agents or susceptibility agents. Kind of an interesting thing. At 64 millitesla, I haven't personally done experiments with gadolinium at 64 millitesla. It certainly works better than it does at ultra low magnetic field. But I would say that the use of other types of contrast agents is going to be part of the recipe. The neat thing about these iron oxide SPIONS is that you can also functionalize them. So you can target them for all sorts of interesting molecular imaging approaches. And so again, whereas gadolinium kind of tells you blood-brain barrier breakdown and other kinds of, angiogenic activity, targeted MRI contrast agents can tell you lots of interesting other things, right? And so I think it's an opportunity.
Right, I'm really excited for it.
Yeah, it's great. I mean, we're continuing that work. We just did a pilot study in rats, which is in that paper. But we're trying some targeted work right now.
Right, and I'm really happy that you pointed me in the direction of that paper, because I never would have found it had it not been for you.
Oh, cool.
So what's been the feedback from neuroradiologists? Any positive or constructive feedback that has stood out to you from medical professionals using Swoop?
Yeah, so I'm biased for a couple of reasons. I mean, I'm explicitly biased because, of course, I'm a co-founder and equity holder in Hyperfine. So I'm not going to tell you that people tell me it's terrible, okay? But that's not what I mean. I'm biased because, of course, I'm in an academic medical center, right? I'm at the Mass General Hospital and the Martino Center. And generally, the clinicians there are clinician scientists who are really interested in tools and in changing the way healthcare is provided. So across the board, I would say people have either been enthusiastic right from the start, or skeptical and now enthusiastic. And it breaks down in kind of interesting things depending on maybe how old the clinician is and how long they've been practicing, which group they fell into. But I think mostly it's I would say neuroradiologists, physicians in general, they're pretty conservative for good reason, right? They don't want to run off and they're taking care of sick people, right? Unlike me, fooling around with transistors, right? Like, it's different when you're taking care of people. And so they are appropriately conservative, and they like data and they like clinical studies. And so it's certainly true. People would come by my laboratory in the early days, in the 2010s, and they would say, "Oh, this is cool. Wouldn't it be cool if we could have portable MRI?" Then here it is, portable MRI shows up, and they're like, "Wow, it's really here. Is it good? Is it good enough? Let me see the let me see the images." Right? Everybody wants the images. And now, of course, we have two, very highly, cited papers where people can see the images. And then there are other groups also publishing in this space. So I would say overall, people are very excited about it. And, clinicians get it. They are understanding that, oh yeah, they're not trying to replace high field MRI. This is the MRI that can go where the MRI can't. And, it's the fact that our first paper was in the COVID wards brought this home. There would have been no imaging in those patients without it. So that's pretty interesting. And then, of course, there are, in addition to all the domestic things that are going on, there are 2 scanners that are in Africa. There's one in Uganda in a project led by Steve Schiff, who is a pediatric neurosurgeon who uses it for neurosurgery in post-infectious hydrocephalus. And then there's a scanner in Malawi that's looking at neurological changes from malaria. Again, you think about the footprint, right? The physical footprint, the electrical footprint, the need for shielding, the need for liquid cryogens, all of the things that come with traditional MRI. And you have this little device that, I was getting the play-by-play from Steve Schiff over in Uganda. There's a picture of it coming off of the truck. And then an hour later, there it was taking data, right? You plug in one 110 volt, 15 amp plug, and you can take data. And that, for people who are involved in patient care, again, I always say neurologists and neurocritical care people, that's it. They see that thing. Radiologists, of course, more further away from the point of contact with the patient. They're used to reading high resolution images in the darkened reading room. And so they need to be sort of apprised of the use cases and what their impact has on patient care, and then they get it. It's new. It's new. It's a whole new thing.
And since it's new, so a conventional MRI, a big component of it is the MRI cooling component. And so a typical MRI cooling system relies on a dedicated chilled water system to supply the cold water that cools the various components of the MRI machine, including a cryo cooler. So
and that's just one small part, right? I mean, traditionally you have your liquid nitrogen and your liquid helium dewars.
Okay.
And then you have chillers for the gradient power supplies, and maybe they don't. You have a cryo cooler if you have a low helium system. The Hyperfine scanner isn't like that.
Okay.
There are no liquid cryogens. There's no water cooling. It just plugs into the wall like a toaster.
Wow.
Yeah.
It's amazing stuff. It's really amazing stuff.
Again, there are many points along the way where we should stop and appropriately reflect on the team of engineers down in Guildford. That's one of them, right? The fact that you could miniaturize all of this stuff, leveraging all the experience of all these engineers, everything they learned from Butterfly and then make it low power, make it low cost. That also makes it so the thermal management problem goes away.
Right.
You think about the new. I just bought a new computer this year. I got a MacBook M1 with no fan, right? No fan. And, I was like, oh, that's cool. Who cares? No fan. Well, it's really nice. It's quiet. But then suddenly what happens when you have no fan? Oh, you have a lot better battery lifetime, right? Because you have no fan, because the efficiency of all the electronics is better. So it's this, virtuous cycle where like improving one thing improves another thing. And so,
wow. Really good point.
So the fact that you can just plug it into any electrical outlet, mitigating all of that need for liquid cryogens is a remarkable thing that they've done down in Guildford.
It's a good point. It's truly portable.
It's truly portable, right? It's like, it's portable, but we need an elephant to eat the peanuts that power. There are plenty of things. Look, as a physicist, I can tell you I've seen those kind of things, right? Well-meaning people, who don't have the full perspective, and that's why you get a big team. You get a big engineering team with a real vision, so they can examine this thing holistically.
Great stuff. So, Matt, a lot of my followers are very interested in determining if low field, low cost MRI can be compatible with real time precision neuro MRI interventional technology. When we first spoke about this, you pointed me to MRI-LINACs, I would believe they're
Linux,
pronounced,
yeah.
Linux, to
Yeah.
read about this and if they could be if it could be possible. So, obviously, tumors and organs, the way they aren't static. So MRI-LINAC is used to adapt the radiation treatment plan
Yeah,
based on
exactly.
movement of the tumor or your organs, and also track the motion of the tumor. So it uses continuous MRI to capture multiple images every second to see soft tissue and organ movement, and then to compensate for these movements during the treatment. So could you explain MRI-LINAC a bit more? And do you foresee this could be a synergistic technology with Swoop to dose maybe gene therapies for neuroindications, maybe robotics,
Wow.
maybe brain machine interfaces? I know there's a lot. I know it's a big umbrella, but
Yeah, no, that's awesome. Those are all
Mhm.
awesome things. So right, LINAC is linear accelerator, and there are lots of radiation sources that are used for treatment of tumors. LINACs are one, the proton beam therapy, et cetera. And my former student David Waddington is working on this at the University of Sydney. So yeah, you can go buy a linear accelerator system that has it's not very low field, but I think it's a 0.2 Tesla MRI scanner that's used just as you described to, when you dose something that's near some other vital organ and you're trying to do your treatment planning, you have to take motion into account, right? And so, by taking motion into account, you don't irradiate the things you want to not irradiate,
Mhm.
and you can give more radiation to the thing you want to zap. So it's a win-win. And it relies, as you said, on kind of real-time MRI, coincident with the treatment, be it radiation or be it some other thing that's happening, kind of interventional MRI. There's no reason in the world why you can't do that with things like the Hyperfine Swoop. Those are, again, all that really matters is that the form factor is appropriate, right? So the Hyperfine scanner, of course, is nice and open. And so you can have access, let's say, if you need to get a proton beam in or LINAC, whatever it is. Again, I'm just conjecturing this. But as long as you have access and as long as the machine that delivers the treatment is compatible with the very modest magnetic field of the Hyperfine scanner, these things are entirely compatible. And I would say, you could imagine, if we're just imagining, you could combine all sorts of things. You could combine, well, like we've done at our center, MRI and PET, high field MRI and PET, positron emission tomography. You could do low field MRI and positron emission tomography. You could do all sorts of multimodal things that give you complementary information. I do love the idea of interventional radiology and then kind of extending that towards, individualized therapies. Either maybe it's image guided surgical things, or as we've been talking about, image guided, treatments for cancers and other types of things. Again, as you start to realize, like, this scanner is small. Could I put it on a rotating gantry and shine whatever? Sure, why not, right? It's not like you have a very heavy 3 Tesla liquid filled magnet that you can't imagine picking it up and rotating it around, right? So there are very interesting opportunities.
Right.
You did
Opportunities for
mention
sure.
something. What did you say? You said something about some gene something. I don't know if I know anything about that.
Just like gene therapies for neuroindication, like dosing for neuroindications. Just because
I
I
don't
know anatomy is super important for that.
I see. And how are those delivered?
Typically, there's a company that a lot of the followers probably do follow also. It's called ClearPoint, and they use a cannula. So
I
it's
see.
very precise.
Yes. So that's right. Thank you. That's right. You did tell me about that. So that's kind of very much like what you do with interventional radiology, except instead of putting a catheter in, you're delivering something. Right. So if you can, again, it just comes down to what is the accuracy of the target you need? Do you need to be within 100? Let's say you need to be within 100 microns of some feature. Well, probably not. You're not going to get that with even high field MRI. But if you need to be within a millimeter or so of a target, you could do that with high field MRI. Although, of course, then at high field, you have to worry a little bit about compatibility with the magnetic field.
Right.
It probably would be much easier with low field MRI. If you looked at the access of either the scanner in my laboratory, which is nice and big and open, you can come in from all sides with whatever you want. And similarly, the Hyperfine scanner, you can come in from all sides and deliver things like that. Yeah, personalized medicine. from that's interesting, from a sort of local dosing of these neurotherapeutics is
Exactly.
a big idea.
Right. And so, yeah, right now we're just talking, Hyperfine is definitely sort of in its infancy. We're talking about like a lot of things that can come about. So what are future iterations of low field technology going to look like in your opinion? What needs to be done in order to pivot from brain imaging, maybe perhaps to cervical spine, breast, maybe other extremities? And could you explain a little bit about the coils and, will we need different coils for those different extremities and different body parts?
Yeah, so again, just the easiest thing for me to talk about is what we do in my lab at 6.5 millitesla. And so MRI in general is actually an inherently insensitive technique, okay? This may surprise you because you've seen beautiful images at 3 Tesla, but unlike, say, nuclear medicine techniques where we count single photons, with MRI, we're measuring these ensemble magnetic properties of tissue. And so it's hard, it's really hard. And it's harder at low field. And so to kind of like hedge our bets, we typically make form-fitting receive coils that detect the signal. So if you're doing neuroimaging, the thing is, it fits nicely around your head. It's not some big giant thing way out here because you lose signal, right? So, and that's what we call a coil, a receiver array. And so if you're doing head imaging, you want one that's well optimized to your head. Maybe they come in different sizes. In my lab, they come in different sizes. If you want to do hand or wrist imaging, we have a coil that fits around the hand and the wrist. If you want to do breast imaging, there are coils for that as well. So making these MRI receiver coils it can be quite challenging at high magnetic field. Again, I've tried in this conversation to say magnetic field, but my inclination is to say high frequency. There's a relationship between the magnetic field and the proton Larmor frequency. It's 42 megahertz per Tesla. So we often talk about magnets in terms of their frequency, okay? And so if you're, say, at 3 Tesla, where you're around 100 megahertz, it can be very challenging to build these multiple array. They often have 64 or more elements. Each one of them is tuned to that frequency. They have to be appropriately decoupled. It's a very complicated thing to do. People spend their careers doing it, and they charge a lot of money for these kinds of things. As you drop to lower field and lower frequency, it becomes much easier to build these coils. Again, that's one of the few things that are easier at low magnetic field is the RF engineering. So that means that you can really tailor make coils for the anatomy you want, and it's not a huge deal. So like if you want to do 7 sizes of head coils, it's not that bad. So in addition to the coil, the other thing you need is you need to be able to get the thing you want to image at the isocenter, at the magnetic center of the magnet. So if you have a small magnet and you want to put someone's torso in there, well, you know how that ends up.
Right.
And so one can easily imagine, and this is language I've been talking about for years, purpose-built imagers, right? You have your neuroimager, you have a breast imager, you have a pediatric lung imager, you have an extremity imager. Some of those things you can do in the same imager. Hyperfine has shown neuroimaging and extremity imaging in the same scanner. It's just about access and design. Again, you could build your portable MRI very, very large like this, but then you need more power to operate it. You need more cooling. You need more, etc. Right?
Space.
So making these like purpose-built devices, that's why there's a multiplicity of devices. It's a very different paradigm than the do everything high field MRI scanner, right? I mean, like at our center, we have 3 Tesla, 1.5 and 3, and we have 7 Tesla machines that can be used for anatomical imaging. They can be used for functional imaging. They can be used for all kinds of interesting stuff. And they do all of those things pretty well. And that's what people typically are used to. In this paradigm, it's like, okay, I need the neuroimager or I need the pediatric whatever imager. Again, it's just a different use case. But of course, surgeons are used to things like that. They don't use the same scalpel for everything, right? So there's a beautiful continuum of tools, purpose-built tools, general use tools, and then a whole mixture in between. That's a long. I told you I was going to talk your ear off.
No, I love it. I love it.
I love thinking about the utility of tools. Like we all have our favorite screwdrivers for certain things, and our favorite wrenches for certain things. And you could try to replace all of those screwdrivers with one screwdriver, you won't be so happy. So I think as the use cases evolve, it's a bit of a chicken and an egg problem. But as people ask for it, boy, wouldn't it be awesome to do, say, instead of mammography, can we do breast imaging with MR?
Right.
It's well known actually that MR, you can do breast imaging MR right now, but again, it's not so common because it's expensive. But as there's need for it, as the research studies demand it, you can do breast imaging at low field, and hopefully the outcomes will be appropriate predictive value, and it again becomes a way to improve breast imaging. Low field MRI is really great for breast imaging, or hope it seems like it will be really great, especially in cases of dense breast. And so there's a lot of enthusiasm in that case. I have actually a proposal with Katie Keenan at NIST, with the NIH, in fact, to do some low field breast imaging at our center in my lab with our 6.5 millitesla scan.
And forgive me, I'm just like thinking out loud here, Matt. Like I can even imagine a future where the swoop comes to you, like maybe, for example, for older patients who can't necessarily leave their homes and need like a mammogram or something, exactly. The swoop comes to your home and you can do the scan that you need.
Exactly. Just think about access. I think we've learned a lot about telemedicine. Of course, telemedicine for stroke has been done for a long time. It really started getting used for a lot of things during the COVID-19 pandemic. If you can get additional information, more than you can just get, say, from examining a patient with a camera and through their vital signs, but instead you can have some kind of MRI, it's easy to imagine, again, that would improve the ability to help, triage and treat patients. One thing I've always talked about, again, I'm not an MD, that's pretty obvious. But think about chemotherapy, right? So you give chemotherapy, let's say someone has a brain tumor and you are prescribed some chemotherapy regimen, and then you come back in let's say a month and you get another scan, right? And then the oncologist maybe changes the cocktail a little bit, and then you get another scan. What if, you could get scanned every day? Would that tell you, could you see the slope, right? So you're scanned every day and you do all the morphological analysis and you calculate the tumor volume. Could you make decisions about changing, say, the chemotherapy cocktail sooner, right? Again, you could do that now with high field MRI, but it becomes, I think it's cost and resource prohibitive to imagine that, wow, we're going to take these sick people, and we're going to force them every day to get an MRI. They're still, it's a lot of work and it's expensive, right? But imagine, since we're imagining, someone's got a scanner. I don't want to say a scanner at home, but let's say they've got a scanner at home, right? And then they lie down for their afternoon nap, and then it goes off to their oncologist and they make decisions. These things, they strike me, and I could be very naive, but they strike me as adding more information that could potentially affect outcome. That's what I care about, right? You could scan your elbow every day just for fun. It doesn't matter. But if you have something where there's a question, is this chemotherapeutic agent the right one? Is the dosing right? Like you were saying, is this designer molecule in the right place? Is this radiotherapy bead in the prostate in the right place? Have things move? Those questions can all be answered, and they become possible when the price of the scanner and the ubiquity of the scanner and the portability and safety of the scanner increases. Sorry. I think I got the sign wrong. The price drops, everything else goes up. Right.
Yeah.
Sorry.
And I just think it's just more information, relevant information that you can feed to machine learning. I don't know, I'm not a machine learning guy, but it's just more helpful information. You give it good info, you get good info out.
Yeah, these machine learning approaches are so different from the way we're traditionally taught to think, in that the more orthogonal, the more degrees of freedom of the information you give it, the better the prognostic value.
Right.
And so combining ultrasound with MR, with EKG, with, things that coming off your smartphone, like your stride, how your gait, right? All of these things, Yeah, there's all sorts of things you could imagine. Right.
Interesting.
Yep.
So, Matt, I don't want to take up too much of your time, but the interview was really, really great. I'm really appreciative of it. Thank you for
Oh, it's
joining
fun.
me. I just want to point out that Dr. Rosen's handle on Twitter is at RosenLab. Correct me if I'm wrong.
That's
So
correct.
he's a great follow. Go ahead and shoot him a follow. He's one of my favorites. Yeah, and if you have anything else to add, Dr. Rosen, go ahead.
Well, come check out, if you go to my Twitter page, that'll get you to my lab page, my group page at the Martino Center. I actually just updated the publications section in advance of this interview. So all the papers we were talking about, they're all up there as PDFs, download them, read them, shoot me an email. Yeah, let's keep talking about science and medicine.
Awesome. All right, everybody. Thank you for listening in.
Thanks so much.